Hi everyone, welcome back to the EKG sessions. This is the second EKG module titled My Heart Will Go On, How to Interpret an EKG. So here's a picture of an EKG in all its glory. I'm assuming that most of you have seen at least the one EKG in your medical career, but in case you haven't, here is a nice example of one. So let's start off by looking at the basic unit of the EKG. And here we can see a single complex, which has been conveniently color-coded and separated into its different segments. And now we'll take a look at each wave and segment individually. So the first segment we're going to take a look at is our P wave, and this is the first part of the EKG complex that you will identify when looking at your rhythm. On our EKG, the P wave is going to represent atrial depolarization. This can be seen as a small deflection wave and the initial wave in the EKG complex. So next we have our PR interval, and this essentially represents the conduction through the AV node. As you can see from the image on the screen, the PR interval begins at the beginning of the P wave and terminates at the beginning of the R wave. As a quick EKG trivia, PR segment abnormalities mainly occur in two conditions. This is pericarditis and atrial ischemia. So moving on, the next thing we're going to identify is going to be our Q wave, which is not always present. But however, when present, it does typically correspond to depolarization of the interventricular septum. However, they can also signal an old MI, in which case they're typically big and wide. So the next part of our QRS complex is going to be our R wave. The R wave typically reflects depolarization of the main mass of the ventricles, hence it's typically the largest wave seen in the EKG and in the QRS complex. And the final wave in the QRS complex is going to be the S wave, and this signifies the final depolarization of the ventricles. Moving on, we have our ST segment, which basically is the time between the end of the QRS complex and the start of the T wave. This reflects a period of zero potential between the ventricular depolarization and repolarization. And finally, we have our T waves, which represent ventricular repolarization. Another quick EKG trivia, atrial repolarization is obscured by the large QRS complex, and that's why it's not typically seen on EKG. So next we're going to tackle the most important part, and that's how to interpret the EKG in the emergency department. So let's start with some basic concepts first. The first concept being rate. The easiest way that I like to do this is I like to take the number of 300 and divide it by the number of big boxes in between two R peaks. The bad thing about this method is that by only looking at two R peaks, if you have an irregular rhythm such as atrial fibrillation, you're not going to get an accurate rate. Another method you could do is to take the number of R waves times 60 divided by the length of strips in seconds, and this will also give you a little more accurate picture of your rate, especially in instances when you have an irregular rhythm such as atrial fibrillation. The other way that you can do this is just to look at the top of the EKG, which actually works very nicely most of the time. So let's do a quick example of this. When looking at this EKG here, which is a pretty normal sinus rhythm, we're going to first use the 300 method, and then we can use the other method which I mentioned. So let's take any two R peaks located on the rhythm strip, and as you can see, there's approximately between 4 to 5 boxes in between each R peak at any given point on the rhythm strip. So if we take 300 and divide it by 4.5, it equals about 66 beats per minute. Now typically I'm not going to divide by 4.5, so you can divide by 4 or 5 and get your answer there. You'll be close enough. The other way you could do it is take the number of R waves that you see in the rhythm strip. Here, when looking at lead 2 at the bottom, there are 11 total R peaks. So if you take 11 times 60 divided by 10, which is 6, you're going to get 66 beats per minute, which is equal to approximately the same rate that we got by using the 300 method. So let's move on to our next basic concept, and that is the axis. So first of all, we have to define what a normal axis is. Typically, a normal axis is between about negative 30 degrees up until about positive 90 degrees. So how can we determine this quickly when looking at our EKG in the emergency department? The easiest way to do this is to look at leads 1 and leads AVF. When looking at our 360-degree diagram at the bottom of the screen here, we can see that between negative 90 degrees and positive 90 degrees, we're going to have a positive deflection in lead 1. If we look at lead AVF now, we see that between 180 degrees and 0 degrees, we're going to have a positive deflection in AVF. Therefore, if we have a positive deflection in both AVF and in lead 1, we know that we're going to be normal axis. This is depicted in the diagram by the green squiggly line which I so artistically drew. So moving on, if we have a positive deflection in lead 1 and a negative deflection in lead AVF, then we have possible left axis deviation. Continuing negative deflection in lead 1 and a positive deflection AVF, we have right axis deviation. And then if we have a negative deflection in both 1 and AVF, we have extreme axis deviation. So the reason that the rule is only possible left axis deviation for positive deflection in lead 1 and negative deflection in AVF is that because the normal axis extends to negative 30. Therefore, using this rule, you can only technically be positive in lead 1 and minus in lead AVF and still have a normal axis. If this is the case, you'll need to look at the other leads in order to more carefully analyze the axis. Looking at the ECG here, we see that there's a positive deflection in lead 1 as well as a positive deflection in lead AVF. Hence, this is a normal axis. So now let's talk about a couple different methods that we can use to help us interpret EKGs while in the emergency department. Two methods that I think are very useful are the rule of fours and the two-step approach. So starting with the rule of fours, we have three categories with four different components in each category. These categories include 4 initial features, 4 waves, and 4 intervals. So starting out with the 4 initial features, our first one is going to be our history and our clinical picture. This should include patient age, sex, symptoms, and your history of present illness. This will help you guide your differential and help you interpret your EKG in the appropriate clinical context. Also, take a second to check your leads. Check your AVR, make sure it's upside down, P, QRS, and T waves. Check AVL and AVR, which should generally be mirror images of each other. And additionally, look for RS pattern in V1, changing progressively to QR pattern in V6. This will help ensure that you have accurate placement of your leads. The next feature we're going to look at is going to be the rate. In a normal adult, heart rate is typically between 60 to 100 beats per minute. Less than 60 beats per minute is going to be bradycardia, and greater than 100 beats per minute is going to be tachycardia. The third feature we're going to look at is going to be the rhythm. Is the rhythm sinus, or is it a different rhythm? If so, then what rhythm is it? This is extremely important to pay attention to in the emergency department, as an irregular rhythm can be a matter of life and death. The last feature we need to take a look at in this category is going to be the axis. It's really not that important to get too hung up on this in the emergency department. Just make sure that overall it's in the right direction. The next category in the rule of fours is going to be the waves. Here we have 4 waves that we're going to look at. The first wave we're going to look at is going to be our P wave. This is typically best seen in lead 2. Just look very quickly for any acute abnormalities. Next we have our QRS wave. Look for Q waves in all leads, as this can be a sign of ischemia or prior infarct. Also look at the amplitude and look for R wave progression in the chest leads. The third wave to look at is going to be your T wave. Look for any T wave inversion, T wave concordance or discordance with the QRS complex, and any presence of T wave flattening. These can all be indicators of acute emergent pathology and need to be looked at further. The final wave you want to look for is going to be a U wave. A U wave if present could be an indicator of hypokalemia and needs to be assessed further. Our final category in the rule of 4 is going to be intervals. There are 4 intervals once again that we're going to look at. First one being the PR interval. The typical PR interval should be between 0.12 and 0.2 seconds. If it's prolonged, does this mean that the patient has a heart block? And if so, what kind do they have? If it's shortened, do they have a pre-excitation syndrome, such as WPW or LPL? After looking at the PR interval, we want to take a look at the QRS width. Typically, this is less than 0.12 seconds. Any widening of this suggests some sort of conduction defect with left or right bundle branches. Next, we take a look at the ST segment, also known as the ST interval. This is probably the most important thing to look at emergently in the ER, especially for patients presenting with chest pain. Look for any elevations, any depressions, or any abnormal sloping, etc. Finally, take a quick look at the QT interval. Is it prolonged? Make sure that the QT corrected is less than 450 in males and less than 470 in females. Significant prolongation could be indication of medication side effect or a genetic abnormality. Either way, this can result in fatal arrhythmia and should be assessed further. So the second method we're going to observe is going to be the two-step method. Two-step method uses 2 mnemonics to go through the EKGs. The first step is going to be used to evaluate all elements of the EKG systematically, and the second step is going to look for diseases that may have caused the abnormalities noted in step 1. So for step 1, we're going to use the mnemonic A rare PQRST. Here, the A stands for age, or different ages, which can have different most common diagnoses. The R stands for rate, as in is it fast or slow. Again, A is for axis, which are we looking for a normal, or is there left or right axis deviation? The R is going to be for rhythm, as in regular or irregular. And then E is going to be evaluate each EKG element as follows. So look at the P wave. Is it peaked or absent? Is the PR interval shortened or prolonged? Are there any signs of heart blocks? Look at the Q wave. Is it deep, indicating signs of prior infarction? Also, look to see if the QT interval is shortened or prolonged. Next, we have the R wave. Is it tall? Look at the QRS length. Is it wide, indicating possible right or left bundle branch blocks? Next, take a look at the ST segment. Make sure there's no elevation or depression. And finally, look at the T wave. Is it peaked or inverted? Any signs of any U waves? So the second step in this method is going to be the mnemonic Dr. III, And here we're looking for possible causes to any of the abnormalities which we might have discovered in the previous step. Here, D stands for drugs, looking for anything such as TCAs, digoxin, or other possible drug overdoses or side effects. R stands for rhythm and rate abnormalities, such as AV block of first, second, or third degree, atrial fibrillation, supraventricular tachycardias, any interval prolongation. Next, could this be ischemia causing this? Maybe there's possible old infarct. Look for any deep Q waves indicating this. Next, we look for infection. Could this be pericarditis? Next, we have enlargement. Any right ventricular hypertrophy, left ventricular hypertrophy, or atrial enlargement causing the abnormalities on EKG? Could any electrolyte disturbances be causing this, including hypo or hyperkalemia or hypercalcemia? Finally, could any endocrine causes be causing this, including hypothyroidism, etc.? So that's the end of the EKG interpretation lecture. I hope it was helpful to you, and I hope it gave you some ideas on ways that you can develop your own method for interpreting EKGs in the emergency department. Thank you.